Hello, everyone. I'm Professor Veena. I'm a professor at Ramya College of Physiotherapy, Bangalore, and I'm also the Chief of Cardiac Rehab program at Ramya Memorial Hospital. We have been using tech-based treatment solutions for cardiac rehab from quite some time now. And initially, we used to use a conventional method of cardiac rehab, and now this is a lot more efficient, more objective, more patient-centric, and real-time data we derive from that. And all of this work is towards delivering quality-based cardiac rehab program. So today we have with us two eminent scientists. So we'll have with us Professor Thomas. He's a sports scientist at German Sports University Cologne. He specialized in exercise therapy in internal diseases at the Institute of Cardiology and Sports Medicine. He will take us through a journey of how cardiac rehab is being practiced in Germany and what have been his experiences. Welcome, Professor Thomas.
Thank you. Welcome. Okay, I start now. I have to Please, can you see my slides?
Yes, we can.
Okay, perfect. That's a good. Okay.
Before
Yes.
we one more thing before we start, if all of you have any questions, you can kindly put them on the chat box so we can have it at the end of the session.
Perfect.
Thanks, Professor Thomas. Yeah.
Yes, thank you for the introduction. My name is Thomas Schmidt. I'm from Germany. I'm from Cologne, and I'm a sports scientist. And I'm working at the German Sports University Cologne. And you can see here our university next to the stadium. And it's a big university all about sports and about everything, about tourism, about journalism, about ethics, but also about sports medicine. And we have two different departments for sports medicine. Department 2 is about more animal studies or biopsies and so. And Department 1, where I work, it's more about people and patients, and it's called Preventive and Rehabilitative Sports and Performance Medicine. We have two big topics in our institute. The first topic is high performance sports. That means that we have the Olympic athletes for us at our institute to investigate for health reasons, but of course also for training purposes. But if you want to know something about this topic, I'm not the right guy for that. I'm about the second topic. It's about patients. Because we are doing sports and movement, we see that this is exercise is medicine. And my professorship is about sports and movement therapy in patients with internal diseases. So what we are doing now in current project, I just want to introduce you some project is not only rehabilitation, but also prehabilitation. Rehabilitation means, for example, that we will prepare patients before surgery. This is the surgery, and we will prepare patients before surgery to increase functional capacity and so on, so that the recovery is improved and enhanced after surgery. And this is important because we know that especially frail patients and old and weak patients have an increased risk for complications like delirium, like prolonged hospitalization stay and so on. And so we do a multi-center study in Germany with a lot of centers, more than 420 patients, coronary artery disease and valvular heart disease. And we do an inpatient prehab program of 14 days and a multimodal program. And we now could include 400 patients or 422 patients, and we will now see the results in 1 year because the follow-up is 1 year, and we will see what happens. What we are not also doing is we do exercise in our institute in the field of resistance training, because if we talk about cardiac patients and rehabilitation, so traditional way is endurance exercise training. This is what we know from 50, 60 years, endurance exercise training. Resistance exercise training is, it was not common before, but now it's coming more and more and more. And we know this is important and that resistance exercise has beneficial effects in our patients in comparison to endurance exercise training the same way in some parameters. But however, of course, there are some fears, there are some dangerous thinking about the hemodynamic adaptations, about the blood pressure response, acute blood pressure response in our patients. And that is what we are investigating now. We are investigating now resistance exercise training, 4 different training modalities, like you can see here, the leg press, and we do also a wall squat with 2 different angles to set up different intensity stages. Also the leg press with 80% of runner M and 40% of runner M. We're doing also a hand grip isometric exercise, and we are doing breathing exercises at 2 different intensities, and we are looking for the continuous hemodynamic adaptations. We can see here at our device real-time blood pressure values, and then we are investigating our patients. The study is currently ongoing, so we have now included maybe 15 patients. We want to include 20 patients, and just to have an overview or a first idea what we will see, it's here you can see the wall squat. In red it's a systolic blood pressure. During rest it's normal, like 120, and if you do wall squat at an angle of 115 degree for 90 seconds, you will see the increase in blood pressure to maybe 210. Then we have a pause of 2 minutes, and then the second step is 220, 225, 20, like this something. So that means that the peak values will increase with SATs, and that the restoration may not be sufficient to get enough for this blood pressure values in peak, and the peak values are more than 220 systolic. If we now compare these values to dynamic exercise at the leg press, 80%, we see that here 3 sets, 1 set, 2 sets, 3 sets. Again, we have peak values increasing with the sets. You see here 170, 180, and here 190. The peak values will increase with the set. That means that the restoration is not sufficient for these patients, but the peak values are lower than for wall squat, and this is also interesting, and we will analyze in the next months. We are doing also other research and science with special populations, heart failure populations. You can see me here with the patients with a left ventricular assist device. It means these patients are waiting for a heart transplant, but of course, in Germany, maybe also in India, the number of heart transplantation is limited, so we can help the patients with a device. The device has a size of, maybe you can see here, like a golf ball. It's small nowadays, and these are good devices, the best we have, and they work with a continuous flow. So normally our heart works with a pulsative flow. These devices are working with a continuous flow. That means that these patients don't have a pulse. No pulse in these patients. And this is a little bit complicated to measure blood pressure and heart rate sometimes, but it's possible with appropriate methods. And one special thing in these patients is that this pump, the speed of this pump is fixed. That means if you go the stairs up and down, normally if we do it, our heart rate will increase. But in these patients, this pump will stay at the same speed. So this is a problem for exercise capacity, and we did a lot of investigation in this field, and this is interesting, I guess. So we are not also doing only the LVAD patients, but also the heart transplant patients as an alternative. And also here are interesting questions, because we all know that during heart transplantation, all nerve fibers are cutted. So sympathicus and parasympathicus are not working as before, especially for the cardiac control. So we see typically an increased heart rate at rest, like 90 to 100. That's normal for a heart transplant patient, at least in the early phase, because parasympathicus cannot work in the first time. So, and then we see under exercise that the heart rate, this is the heart rate, this is the exercise, this is the control group, will increase delayed. There is delayed increase of heart rate, and also the peak value it's not so good like in a normal patient. Also recovery is delayed, and this is called a chronotropic incompetence, and we know it in these patients, and we did a lot of investigations in our patients, and also sometimes special questions, because these patients ask me if you can go to scuba diving after heart transplant, and this is interesting and complicated if you compare scuba diving physiology to heart transplant physiology to compare it. But we find a solution, and now she is diving with a lot of fun. So we are doing also other project, not only in adults, but also in children. A new project already started. Yesterday, we submitted the ethical approval. It's about children with congenital heart disease. And as you know, luckily, fortunately, now the patients, the children have a good perspective, and survival is good with our operation methods. But however, we know that these children are protected by the parents, by the whole environment, so that we say, okay, exercise and I don't know, don't too much, you know what I mean. They are protected. And in our opinion, they are possible to do something, and we want them to show that they can do something. And so we do a pilot project in cooperation with University Hospital and also with the SC Cologne. It's a local football club, and we do walking football for children with congenital heart disease, and it will start in March, hopefully. As I told you, the ethical approval is already submitted. Then we have another project, just as an idea, not only in the field of cardiology, but also in the field of chronic kidney disease. This is somewhat the same idea. These patients, these children are also waiting for a transplant, a kidney transplant. And in Germany, as a child, you will wait for 2 to 5 years. And that means that the children has to come to hemodialysis between 3 to 5 times a week for 4 to 6 hours it takes for years to become a transplant. And that means that physical activity in these patients is also limited. And what we are doing now is we try to bring the physical activity to the clinic doing the hemodialysis, and this is not easy, but it's interesting. And because in adults it is well known that it's feasible to do it, but normally you will use a bed ergometer. Yes, a bed ergometer you're lying in the bed, but for children, you can imagine that lying in your bed and doing ergometry while lying, it's not so motivating. So we thought to try something new, motivating, and we built an exergaming intervention. That means exercise and gaming combined, so they can do exercise with the feet, and there's a sensor, and it will be and then they can control a game, and the children can see the game in the screen. And this is a current project, a really nice project, and we have a lot of fun, and also the children have a lot of fun, and we want to continue with this project. You see the pictures here. These are nice pictures, and you can imagine that at the left and at the right side there are also other children, and they are motivating these children. Go more, go faster. I did this, do also. And so this is a nice way to make the hemodialysis also beneficial for physical activity and physical capacity. Okay, so now I told you before what we are doing, but why we are doing this, and this is we know now that this is beneficial what we are doing, but the history is not so clear. 100 years ago, there is Professor Parkinson, and he supposed in the Lancet, it's a really good journal, that in patients with myocardial infarction, before it was the rule that rest in bed for not less than a month is imperative to allow healing of the infarction. That means bed rest was the normal condition after infarction, and the return to ordinary life should be postponed as long as possible. That was the rule 100 years ago, and that means that the patients were not able or not allowed to go stairs for your 1 year sometimes. And you can think what this means for you. If you go for 1 year no stairs, for a private life, for a job life, and also for your muscles. And this is horrible for your muscles. But fortunately, there was a development during the 15th to 17th in this issue. And you can see here, this is Professor Dr. Wilde Hollmann. And Wilde Hollmann is a former of our institute at Cologne, and he did some really good investigations. You see here an old bike, and you see here the old CPAP mask. This is the mask in the 50s. Yes, this is the mask. This is the old bike, and he did the pilot investigations in cardiac patients, and there was then a paradigm shift. So now first start to do this in cardiac patients. And you can see here on the right side the very old ergometry bicycle system. It looks before. Today, Cheese will show you how it looks today. So, and we now know that physical activity is beneficial in heart failure, especially in different modalities and different aspects, as a polyp, inflammation, insulin resistance, and so on. However, this is for us important, and we do our research on this for the patient. The patient doesn't interest the LDL value because he can't feel the LDL value. For the patient, it's important hard endpoints like mortality, quality of life, exercise capacity. This is important for the patients, and we see that exercise therapy or physical activity is also beneficial for these hard endpoints. We see here cardiovascular disease, that risk of mortality decreases with increasing physical activity, and the decrease is more pronounced in cardiovascular disease comparison to no cardiovascular disease. So it's beneficial in our patients. And that's why we are doing it in a regular basis in Germany and hopefully also in India. And we're doing it in our institute at the German Sports University. You can see here our groups. We have in total 24 outpatient ambulatory heart groups in our institute, and we are not a hospital, we are a sports university. So, and you can see here not only the patients and me, but also our young people. And don't worry, these are not patients. These are our students, and they are working with the patients, and we teach the students how to work with the patients, and it's always a nice combination, and all have fun, and it's useful, I think, to have these combinations. So, and as I told you, exercise therapy is beneficial. We know for coronary artery disease in these aspects, the exercise capacity, quality of life, rehospitalization and survival, and also for heart failure, HFrEF and HFpEF, the evidence is there. So what we are doing now really in our institute, so we have different groups. I told you 24. We have some groups, indoor groups, where we can do, especially in the winter, we can do some games, we do coordination games, we do everything indoor in gymnastic halls. Then if the weather is fine, we will also go outside, because outside is always a good feeling for the patient, and it's also near to the patient. They can do the same exercise also at home during the pause days the same way. You don't need much material. And then, of course, we have machine-based exercise training in our institute under ECG monitoring. On the left side, you can see our ergometry machines, and on the right side, our resistance training machines we use on a regular basis. So today we will talk about the monitoring of ErgoLine, of the ergometer machines, and in my opinion, there are some benefits to use it, because as I told you, we have different patients with different constellations. The ergometry setting, it's a controlled setting, yes. There is no risk of falls. If you go on a bicycle, it's safe. If you go into a gymnastic hall or outside or to the swimming pool, so swimming pool is no risk of fall, of course, but at the gymnastic hall, if you play walking football or something like this, there could be risk of falls. During our ergometry sessions, we have the choice, and this is really good, to control the exact training loads. If you go outside, we can now say this is 120 watts, this is 150 watts. It's not possible to do it in every patient. So, but if the patient is on an ergometer, we can set up the exact training loads for these patients. And so we have also the possibility to do a protocol for each patient. And each patient individualized protocol. So like this, and this is also important, because if we have our groups and we have one exercise intervention for our groups, like we are playing walking football, it's different for every patient. But at our ergometry bicycles, we can adjust it for every patient. So, and it's also possible to collect key parameters like the load, heart rate, blood pressure, and ECG. This is important in terms of safety. And we have a possibility to have a look to the training documentation and comparison. That means if a patient comes to you after the training and said, Thomas, there was something, I felt something. So what we are doing then, we can go to the system, have a look what happened for the EG, and then we can go 1 week before or 2 weeks before and have a look if this happens again or before. Yes, to have an idea if this is new or if this is common in this patient. So this is also good, and I think this ergometry by Ergoline is efficient because you can control. In our setting we have 10 ergometers and only one therapist, and it's easy to control 10 patients in an individualized way. So you can now say, Thomas, for whom this is beneficial? And then I say, not every patient needs this. This is clear. We also have patients, they don't need this as mandatory step. But especially in the early phase after cardiac event, this is, in my opinion, beneficial for the patient and also for the therapist to gain trust. Yes, to learn how your body reacts, how now with the new medications and after stenting or bypass operation, everything works. It's for the early phase, it's very, very important in my opinion. And especially in weak or high risk patients, as I told you, the patients with left ventricular assist devices, they have a drive line here. That means that so there is some safety issues and risk of falling. It's increased when something happens in these patients. So for these patients, this control setting is also very beneficial. And of course, in patients who need psychological support, because we have every key parameters, we can show them. No, it's like you did on the CPAD during the exercise test. It's normal for you, and you will learn it. So, and of course, I was now talking about the ergometry, the endurance exercise interventions, and as I shown you that we also do resistance exercise, we using also the system to have a monitored resistance exercise training. And this was, in our case, one time crucial and important because we had one patient, he had a syncope. He had a syncope after resistance exercise, and of course, we were not able to say what was the reason for that. Hopefully, everything went well, but then we had the opportunity to go into this data to see what about the rhythm before the syncope, and we saw that the rhythm was okay. It was most likely about the blood pressure, but not about the rhythm. So it was also good to have this idea for resistance exercise, what happens in this case. And now I want to just have some comments about the different protocols during the endurance exercise training. Of course, you know, there are different protocols, there are interval protocols, there are moderate continuous training protocols, and we know, and this is important, that both forms are effective. Both forms works. So this is important. Of course, if you take a look to the literature, you will see that sometimes in smaller studies, the high intensity protocols are somewhat better. Yes, and this is true. That seems to be true that intensity is a big fact. But the most important thing, and this is what I really want to share with you, is the compliance. So if you prescribe a patient a protocol, this is the best protocol from evidence, but the patients will not do the protocol. It's the wrong protocol for the patient. So, and this is what we see. If we prescribe a patient a protocol like this and he is not able to do it, then it's the wrong protocol. So, and in my opinion, you should introduce the patient both protocols and then ask him what is okay for you. Do you accept both protocols? And if he said, no, it's totally okay for me, I like this more, and I'm able to do this, then you can decide, okay, maybe HIIT is somewhat better in terms of the results, but you have to do it. And when you do show the patients how to train it, it's important for me not to start from 0 to 100. You need a progressive increase, yes? Not to start from 0 to 100, just start with 2 protocols, 2 intervals, short intervals, and then increase over time to 4 intervals of 4 minutes maybe, because otherwise it's an overload. it's an overload for the patient. You need to have a progressive increase, not also for the interval methods, also for the moderate intensity continuous methods. You see here, we increase the exercise time over weeks. So this is important for the patient. And as I told you, we are not a hospital, we are a university. That means we are also teaching students, and I use our system also for the students to teach them. And we use also our system for scientific studies. And this is also what I want to share with you is if you say the patient recommend the patient a specific protocol, you should also do the protocol by yourself. And this is what we do here with our students. We say, okay, if you say to the patients you need to bicycle at 90% of your peak watt, this is a high intensity. You need to know how does this feels. And this is what they are doing now here. They are doing their own protocols, high intensity protocols to experience how this feels. And this is important to have a good connection to the patient. So I'm not a physician, I'm not a technician, but I'm a researcher, and that's why the second part about the system is about teen. I hope you had an overview of what we are doing and what we are thinking about cardiac rehab in Germany. Thank you for your attention, and questions maybe later. Thank you.
Thanks, Professor Thomas. Yeah, that was a good insight. I would agree, or I would vouch with you on 2 or 3 aspects when you told objective. Definitely, the ergometers are very objective, because previously when we used to do conventional cardiac rehab, we never knew whether you are working at 30% or 40% of your maximum heart rate. You're just doing it arbitrarily. And by the time we go and measure the blood pressure, already the blood pressure has changed. So this helps us to do real time. So we know what's happening and are you in the target zone of the exercising the patient. Second thing is about safety, safety, which you told. Because we can treat about 8 to 10 patients together at a time, and we have one specialist who is there, who is monitoring everything. And if we decide that a patient's heart rate should not go more than 110 or 115, I don't have to manually go next to every patient and reduce his intensity, but the software automatically reduces the load, so he is in the target zone. So that's the safety which we are looking at any cardiac rehab program.
I just wanted to agree with you. It's a problem in the groups, not on the ergometers, to control the training load in real time. It's not possible in a good way. However, we are doing this with the children with congenital heart disease, with pulse, at least pulse, and we have a tablet, and we can see in real time all the pulses of the children. But it's complicated, and of course we can't control the watt, and so yes.
Yes. Thank you, Professor Thomas. Thank you very much. Now I request Thijn, who is also a specialized in sports scientist from German Sports University, and who is a member of the Ergolan Academy too. And he's also been a former competitive athlete. I now call upon him, and he's going to explain to us about the technology, what is used behind this Ergolan solutions, and how we can cater and use this modules for our clients. Welcome, Thijn.
Thank you, Dr. Veena. Hello to India. Thank you for taking the time this late afternoon on Friday for you and joining this session. We have heard some interesting stories from Dr. Thomas, and I'm continuing with the software and how this software and the cardiac rehab solution is used at the German Sports University, for example, how this looks in general. I will share my screen. Just to introduce myself, my name is Thijn. I'm originally from the Netherlands, but I've lived in Germany for about 18 years, and I've attended the German Sports University, the same as Dr. Thomas has been talking about. So that was about 20 years ago, and since then I've been in the sports and health industry, and I'm part of the Ergolan Academy at this time. So I will tell you about the software part in the cardiac rehab solution and the benefits of software-supported cardiac group training and all the compliance with guidelines for medical training, so which is based on exercise prescription by a therapist or probably a doctor in this case. This software offers a central management system with real-time supervision of relevant data like ECG, blood pressure, SpO2, but also load if you are exercising on a training device like an upright bicycle ergometer. So this covers the safety aspect of exercise. Then we have accessible reports, for example, individual treatment plans, which tracks the patient's journey in the cardiac rehab, which can be important for insurance or for hospital and for reimbursement. So this is the quality control part of the system. And then, of course, a huge advantage of the software and the complete cardiac solution in combination with devices or with free training is that it allows group training and a safe training with multiple patients and one or maybe two therapists. So as a standard, we say one therapist and 12 patients. I've seen in a presentation before in the German Sports University, it was 1 to 10 patients. It depends on the experience of the therapist and also, of course, on the state of the patients. We all know exercise is good for us, for everybody, for every patient. Some of the patients did knew it before. And also we see around the world, since we are a global, well, globally we have different opinions about exercising, and we've seen how the advice was in the 50s and 70s. We have recommendations about from well-known organizations in the world that the treatment of patients or that exercise-based cardiac rehabilitation is class 1 and level A recommendation by the European Society of Cardiology, by the American Heart Association and American College of Cardiology, for example. So it's recommendation class 1 and also A level, so it's evidence-based. So this should help also with convincing therapists and patients if there are doubts about exercising. Then if we go to the function of the software, it offers safe and effective aerobic training with real-time supervision of heart rate, ECG, blood pressure, and SpO2. It allows group training with one system. So a system is a PC with software installed, and you can create systems with up to 24 stations. It also depends, of course, if that's makes sense depending on the patients. So our standard advice is 1 to 10 or 1 to 12. Then the advantage is that you can make individual tailored training plans through one central management system, and the data of the exercise training is automatically saved, and all reports are available in different formats in Excel or PDF. It is available in, so the software, which is called ERS2, is available in different languages. English will be the main language for India. We don't have the different dialects of India, of course, so English will do. We have individual training plans. One of the advantages is also that with this software and the PC, if you have connected training devices like an upright bicycle ergometer, you can control the saddle height or the handlebar height, which makes it easier if a patient is already on the device and it does not need to come off the device first to adjust the height of the handlebar or the saddle. So that can all be done through the software and the PC. You can set alarm functions and so on. To give you an idea where how the whole structure looks like, you'll see the red box here. The red box here. Here we have located the PC and the software with ERS2 connected with screens, of course. And this PC is connected with different devices like upright ergometers, as you see here, bicycle ergometers, or treadmills, or other devices. These are the cables here, the green lines. And then the patient can be connected with a telemetry system via Bluetooth, which will be received through a receiver at the PC. Then the good thing is that there's a database on the PC run by the software, and this software and PC can be connected to the HIS, so the Hospital Information System. It can be integrated in the network through HL7, so there can be a data interchange. Then, of course, we have the patient, we have the software, but we need information also from the patient into the software. There are several options. This is one of the options. It's a telemetry system with a chest strap and an adapter, or, for example, in case it's needed for a patient, it can be through disposable electrodes. With this telemetry system, the patient can do exercising on a training device, but it can also do freely exercise next to a training device or on strength equipment. Other options are integrated modules in a training device, for example, an upright bicycle ergometer. You will see automatic blood pressure module on the right bottom side. You'll see a SpO2 measure module top right over here, and a one-channel ECG in this picture here. Then, if we return to the software, which is then the main system, which runs the complete system with a lot of overviews. And this is one display screen where you will see 6 patients at a time connected and active in this exercise training, so a group training with 6 patients. Here you will see Gertrude Baumann, exercise patient number 1. The second one is Rajesh, he's from India, so this is a good picture. And you will see the vital data here, the heart rate, ECG, and then over here you see the graphs with the vital parameters of blood pressure, SpO2, and heart rate. So this is a screen with 6 patients at once. You can upgrade it up to 8 patients at one screen, and you can add an additional screen with another 8 patients. So in that sense, you can enlarge the group based on your needs. A little bit more in detail. So at the left side here, you see the same display screen as I showed you in the slide before. There are different sections where you can configure the system. So if you look here at the left side with figure 1, this is the management section in the screen. So here all the information of the patient will be visible, as well as at what station is he assigned to, which is important to match with the sensors he's wearing, and what kind of device he is exercising on. Is it a treadmill, or is it an ergometer, or is it something else? Then in the second part, over here, section 2, you will see the heart rate here. So it's the current heart rate, also the training heart rate or target heart rate, and you will see the ECG and blood pressure management as well. Then in the third part, at the right side, which is this part here, it's the control part. So you will see in what training stage the patient is, the protocol type. Is it, for example, an interval training, or is it a constant load training, the duration of the training, and a couple of more parameters. Then over here in the diagram, you will see the measurements of or the information of blood pressure, heart rate, all together at once, and you will see the figures over here in this section. So we've talked about different configurations and options. There are a lot of options in this system, but most regular protocols which are used, also what Dr. Thomas said in the presentation before, are probably interval trainings and continuous load training. In these sections, you have the possibility to create a heart rate controlled protocol, or SpO2 controlled, or a load controlled protocol. And then as a third option, you have user-defined protocols, like the steep Bram test or S-Strand protocol for a submaximal exercise test. To give you an example how this looks like, more in detail. So this is an example of a load-controlled protocol. You will see the blue line here, that it is an interval training. So this is the timeline. At the left, you see the heart rate per minute, and at the right side, you see the load in wattage. So the patient started here with 0 load, or 6 wattage. So then the load will go up to 100 wattage for a couple of minutes. You see the heart rate racing, and then there's an increase of load. The heart rate will go up, and then here's the resting period, and then it will go up again. At the bottom side, you will see the blood pressure in millimeter mercury. So you all have all the data in one overview. So the next example is a heart rate controlled protocol. So it means in the configuration, we have set a maximum heart rate for this patient. He should not go above this heart rate during the training. So in this case, it is 160 beats per minute. So we again have an interval training. The patient starts here with training, the load increases, the heart rate raises as well. And we see the heart rate here in the first interval section is below the maximum, so that's okay. So we continue with the regular protocol. In the next section, we see that at the end of the section, that the heart rate is going above 160. So depending on the delay we have set in the configuration, the load in the next interval, which is here, will go down. So, and that's something you can set in the configuration as well, the percentage of adjustment of load. So in the next section, the load wattage is only 200 watt versus, what was it, 220 maybe before. And we see the heart rate is quite okay, it's going a little bit above, but since we have said that the delay of adjustment, or that there is a delay, and at the end of the section, the heart rate is more or less at 160, there will be no adjustment in the next section of the load. In the case, in this section, the heart rate would be above maximum for a certain time, then the load will go down again. And at the bottom here, you have the blood pressure overview. So that was all about the training and how you can monitor. And then this screen shows the analysis after the training. So you will see the graphs here. So in detail, what we've seen before. You have a summary over here. I see this is in German, but it doesn't matter. You can also display that in English language. So you'll see here the date, the length of the exercise, what kind of exercise or what device the patient has used. And then this is the heart rate, starting heart rate, maximum heart rate, average, and ending heart rate. So, and these are all data you can configure in your reporting. So this is for a single training, and you can also create overviews for multiple trainings over a certain period. So in this case, you see here, this is 20th of July, 2015, and this is 27th of July. And there has been several trainings during this period. And then you will have the summaries at your right side here. So that's the summaries, the training. We have told you that you can set and create different protocols. Just to give you an idea, this is the screen, how it looks like to create a constant workload protocol. So you will have the option over here to set the duration of the warm-up, for example. So it says here 1 minute, but you can increase it or decrease it. then the increase of the load at what time, maybe after 4 minutes, it will go up. You can set the load, the starting load, you can set the training duration, and the decrease at the end of the training and the recovery period. So these are all data you can set individually based on the needs of the patient. Then one important thing is also that you can set patient notifications. You can set maximum heart rate or blood pressure or SpO2. Then you can set an alarm. So standard is none, but you can set an alarm, and then a pop-up window will follow. If, for example, the heart rate is above the set rate. You can also configure the system that it goes into recovery mode at the time when the heart rate exceeds the maximum, or even the whole exercise training terminates if this happens. Some options from a lot, and one of the options we use in a couple of countries, amongst the USA as well, for reimbursement purpose, but also for tracking the whole journey of the rehab program of a patient for hospital or for the therapist. So the individual treatment plan, ITP in brief, tracks the patient's core components during the rehab period, and it tracks also the progress, and it is used for insurance payers for reimbursement services. So it looks in a brief overview like this. So it is not only about the progress in exercising, but there are more sections included here. So information about the patient, about exercise, but also about nutrition and psychosocial details of the patient. So it means you have more information about the patient available to follow the progress of this person. Finally, to recap, this is how a workflow would look like in 4 sections. So you have the management section where you enter data and create a new record, patient record in the software system. You create the training protocol. Then in the next stage, the training preparation. The patient is there, and you would assign it to a place on a device, or maybe in a training room. You give instructions, apply the sensors to get the data, check if the sensors are really received by the PC and software. Then you will go to the training execution to start the training, monitor the training, adapt parameters in case it's needed, perform measurements, and of course, after the training, the patient leaves the training station. And at the end, you have the analysis with reviewing the training summary, print analysis. We also have viewer licenses, so that, for example, a doctor in a different location can view the data in the software as well. This is not something new. We've heard in Germany they have been busy and researching with this since the 1950s already. So in the course of the years, we have installed over 700 ERS software cardiac rehab systems around the world with very good references. Not all countries are at the same stage. So in Germany, we have a lot of rehab centers, and it is well known. And there's a reimbursement system behind it, which supports all these centers also, which is not the case in all countries in the world. So one of the references in Switzerland, Inselspital. This is the German Sports University. You see one of the training rooms in this picture. In Italy, Policlinico San Donato, and of course in India, the Ramaya Memorial Hospital in Bangalore. So recapping everything, we have software-supported cardio group training in compliance with medical training therapy. We have a central management system which offers real-time supervision of relevant data, which is the safety aspect. We have quality control with accessible reports, including individual therapy training. And the software allows group training, safe training with multiple patients at a time. So one therapist up to 10, 12 to 24 patients at once. This was the software part. If you have questions, please feel ahead. And Dr. Veena, I think you want to take over again.
Thank you, Thijn, for that wonderful presentation. We have a couple of minutes left for any of our colleagues probably who want to ask some questions. You can probably raise your hands and probably I can allow you to speak. If anybody has any questions for either Professor Thomas or for Thijn. Okay, Inderpal Singh. Yeah, you can unmute and speak.
Yeah, my question is, that what is the better option, cycling or the treadmill? Like India, most of the people, most of the hospitals prefer treadmill than what I seen in your presentation. Everywhere the cycle has been shown. So which is a better option and why? What is the reason?
This question is for me or for you, Veena?
No, it's for I think it's for you. You have shown everywhere.
Dr. Thomas.
Like all the cardiac tests and
okay.
all the cardiac tests and everything is done in India on treadmill. So which is the better option?
To say better, it's difficult in this terms. If you have a patient with peripheral arterial disease, yes, Germany called peripheral arterial disease, you know, the legs are closed, yes, then you need a treadmill, of course, because treadmill is the treatment of choice in these patients. If you have patients without these problems, you have the opportunity to choose both. But in my opinion, bicycle or ergometry training, it's easy because you don't need much space, there is no risk of falls, and you have a good quality of the ECG sensors. If you do it on a treadmill, and we do it on a regular basis with our athletes, because athletes, if they are marathon runners, so they go on the treadmill. But the ECG, it's difficult because of the artifacts, and of course, the risk of fall, it's there, and so this is the easy way. If you want to train 20 or 12, I don't know, 12 patients at the same time, you need 12 treadmills. So I don't know if this is possible in your clinic. For the ergometers, it's possible, and both has an effect of your cardiac performance. So maybe Veena or Thijn, you can just add.
Yeah, I think using an ergometer is a bike is much better in our Indian scenario. We can do that because the patient feels comfortable as compared to a treadmill. So that's been our experience. Okay.
Okay, thank you.
Thank
and
you.
we are talking also about old patients, yes? Especially in Germany, they are sometimes 80 years old. To go on a treadmill with these old patients, it's difficult. Of course, you can do it in the later stages in collected patients. You could do it, but not as a routine.
And that also we have recommend bikes if we have for older patients. So that's again, safety is there. Okay. Yeah. Okay, then thank you very much. Thank you, Professor Thomas and Thijn, and thanking all the participants, and I thank CAHO for giving us this opportunity to talk on tech-based cardiac rehab.